Well, hello, everyone. Welcome to Pharmacology. This is Tom Viola. I'm going to be your instructor this semester, and this is our first lecture, Introduction to Pharmacology, and we're going to learn all about the basics today. Well, let's dig in, shall we, about pharmacology. And let's talk about how we use medications. Well, what is pharmacology? I guess is a good place to start. Well, pharmacology is the study of drugs and their effects on living organisms. Great. That's a nice textbook definition there, Viola. Can I get some substance? Well, of course, that begs the question, what's a drug? Well, a drug is a substance used for the diagnosis, prevention, or treatment of disease, or for the prevention of pregnancy. Well, that's another good textbook definition. Bottom line is, we're looking at a substance that is used in both the diagnosis, prevention, treatment of disease, and you'll see that the disease states themselves are often indicative of the drug and vice versa. So, as I've often told my students, when a patient tells you what medications they take, with a little knowledge of pharmacology, you can deduce a lot about them, including their current medical conditions, as well as treatment planning and guidelines for future follow-up and future treatment. Well, where do we get these drugs? Where does pharmacology begin? Well, it starts with natural medicine. As a matter of fact, drugs originate in places that are usual and not so usual. Now, our ancestors noticed that ingesting certain substances that were available freely to them in nature altered their body function or even their mental awareness. And to this day, we still get a majority of our drugs from nature, like plants. Digoxin, which is a drug used for congestive heart failure, is isolated from a plant. There are many others. We also get drugs from microorganisms, such as ciprofloxacin. We even get drugs from animals, like conjugated estrogens, which are derived from, if the brand name gives us any clue, pregnant mare's urine, Premarin. And we even get drugs from minerals like silver nitrate. SSD cream is sulfadiazine cream. That's, again, a cream you'd use for burns and some other ailments. But I'm talking to a class full of dental hygienists. So I think we can do a little better than that. How about the most famous drug that was derived from a bug? How about good old penicillin? That was derived from a microorganism, a fungus. And I can't think of a better mineral to use as a drug in dentistry than something you paint on quite literally like varnish, fluoride. So drugs get their origins in many places, even in the lab. So in this situation, we have our patients taking antihypertensives and not liking it. Reason? Side effects. If you can believe this, the number one reason why antihypertensive medications don't work is because simply patients don't take them. Well, why wouldn't they take the medication, you ask? Side effects. Many people feel that they feel better when they don't take the medication, that the medication makes them feel worse than normal, and they'd rather deal with the hypertension and the repercussions than feel awful every day from taking the medication. Well, lo and behold, captopril is introduced many years ago now, but relatively modern considering some of the drugs we still use. Captopril is derived from snake venom, and it has a very positive vasodilative effect. And what that means in English is it causes a lot of vasodilation. And when you blow open the pipes, so to speak, the pressure goes down. Great idea. Captopril is born. Well, the problem with captopril is it has to be taken 4 times a day. And I'll tell you this, my friends, if I was a woman and I was on an oral contraceptive, I'd be pregnant every day of the year. I couldn't remember to take a pill a day if my life depended on it, literally. Well, so great drug, not so great delivery. That's okay. A couple of years later, another company takes the captopril formula, tweaks it slightly, and generates a drug called lisinopril. Lisinopril's claim to fame, its clinical advantage over captopril, twice-a-day dosing. And I'm sure you can fill in the blank here. A few years later, ramipril is introduced. Ramipril's clinical advantage over lisinopril and captopril, once-a-day dosing. So all of these drugs are based on the same technology. And the only clinical advantage to the later comers is that they have solved the problem of multiple dosage units per day. The good news for us, though, is besides the therapeutic advantages, you can tell that almost immediately by looking at the generic names. The last four letters of each are the same, pril, pril, pril. So if you see a pril, you know it's in this drug class. What drug class is this? ACE inhibitors. So that means, I guess 10 years from now when there's Violapril, God willing, you'll know that's an ACE inhibitor invented by yours truly. But don't hold your breath. Well, we could even get drugs from synthetic processes like omeprazole, Prilosec. That's derived specifically because we used an electron microscope to figure out what the receptors look like on the proton pump in your gastric pits, those parietal cells that pump out acid. Well, if we know what the receptor on the proton pump looks like under an electron microscope, we can go to our friend, the organic chemist, and say, hey, could you come up with something that fits this like a key in a lock? Because we want to block those receptors and block the formation of stomach acid. And hence, Nexium, Prilosec, the entire class of proton pump inhibitors was born. We can even get drugs from bugs, but in an entirely different way. For example, human insulin, Humulin, and all of the insulins produced in the United States now are made from E. coli. Now you say, well, wait a minute, isn't that the pathogen? Isn't that the thing that causes flesh-eating disease and too much poopy when I'm on vacation in Mexico? Yes. However, we can alter the genetic structure of E. coli and program it literally, feed it amino acids, and it could make beneficial proteins, as in this case, both human insulin and erythropoietin, which is a hormone used in the production of red blood cells for patients with kidney disease. Fascinating. Well, after watching this video and listening to my voice drone on for a few minutes, you're likely to leave your desk and say, for the love of God, somebody hand me some N4-hydroxyphenylacetamide. This guy never shuts up. You're not going to say that, and I know you wouldn't. That's because no one uses the chemical name of a drug. Most of the time, we use the generic name, acetaminophen. And you could see it's sort of derived from the chemical name. It's a lot easier to say, if you call that easier, but the generic name is the official name of a drug. It's chosen by the United States Adopted Name Council. You mean there's a section of the government whose sole job is to come up with generic names for drugs? Yeah, welcome to bureaucracy. Well, I guess it's important because it is the official name of the drug, and therefore each drug only has one generic name. So acetaminophen is acetaminophen is acetaminophen throughout this country. And notably, the generic name is often lowercase and in parentheses. A lot of people use the brand name, though. It's just easier to say, it's more recognizable. Tylenol, you say. Now, the brand name is not selected by anyone but the company that makes the drug. Once a company invents a drug and gets FDA approval, they have exclusive rights to marketing for some years. And that gives them the right to come up with their own name to market the drug under. In this case, Tylenol. The interesting thing here is, though, while every drug can have only one generic name, which is the official name of the drug, drugs can have several brand names depending on who's marketing the drug at that time. Once the originator company's patent runs out, any company can market that drug under any brand name, but they must keep the same generic name. Typically, the brand name is capitalized. Where am I supposed to get this drug information, Viola? You've assigned this top 100 drugs assignment. Where am I supposed to find this stuff? Well, you can use the physician's desk reference. I've used it often to hold open windows and hold open doors. It's very heavy. How about Mosby's Dental Drug Reference? Well, if you open the cover to the most recent edition, you'll find my name inside. What do I say to that? Love my Elsevier comrades, but don't buy it. Quite frankly, you can get most of your information online, and it's much more up to date. Even the Drug Information Handbook for Dentistry, again, published by some of my esteemed colleagues, great book. I wouldn't buy it. I'd get most of my information online because it's up to date and because it's easy. And I don't have to take more than a few seconds or a quick Google search to find what I'm looking for. Well, why is it important for you to even know pharmacology? Why do I need to know pharmacology as a dental hygienist? Well, because you're going to use pharmacology every day. If you visit my website, one of the things I say all over the place is what? Pharmacology just might be the most important instrument you use every day because you need to know pharmacology to know your patient. And you need to know pharmacology to do your job, like obtaining a complete patient medical history. Some patients know their drugs inside and out. Some will say, yeah, I take the white one. Well, with a little pharmacology knowledge, you can kind of pin it down from there. How about planning appointments? Yeah, I mean, if I tell you I'm on a medication to treat my diabetes type 2, you know I'm probably going to be better off with a morning appointment in most cases. How about handling an office emergency? Would be great to know what's in that emergency kit and how to use it. Administering medications like local anesthesia takes a fairly broad knowledge of local anesthesia to be able to administer it safely and effectively. And even interacting with other healthcare professionals. Maybe you'll call a pharmacist from time to time or a medical doctor. It would be helpful to know the lingo, how to pronounce the drug and what the drug does. Even if you have a beginner's understanding, it's going to help you in the long term. But I can promise you this, my friends. After this course, I think you're going to know more pharmacology than anyone else you work with. That's not due to me. I know how smart you are. I'm going to call you hygieniuses. Well, what's this? Prescription writing? I don't write prescriptions. That's a doctor's job. Yep, that's what I said about 10 years ago about local anesthesia. Local anesthesia, that's for the dentist to administer. Things change pretty quickly in this profession, so you never know. And so we have to give you this crash course in prescription writing just in case. Well, the good news is that most prescription writing now is done electronically, and you can just write out English if you want. But there's still a pretty liberal use of these Latin abbreviations for things, kind of like a shorthand. So QD once a day, BID twice a day, TID 3 times a day, QID 4 times a day, bicycle, tricycle, quad. PC is after meals, AC is before meals. AC equals before meals? Well, how about antes de comida if you speak Spanish, right? The easiest way to remember that, my friends, is AM and PM, right? AM before noon, PM afternoon, AC before meals, PC after meals. PO, by mouth. You might say, well, how the heck did PO become by mouth? Well, the Latin is per os, OS. So you might have a little fun with the clinical faculty when they say, what are you going to do with that instrument? You're going to say, well, obviously, I'm going to stick it in your, you can fill in the blank, folks. PRN, as needed. SIG, write or label, please. This is the instructions from the doc to me, the pharmacist. Hey, write this on the label, stupid. Stat, how about immediately? HS for bedtime? Latin, ora somna, at bedtime. How would you remember that? Say it backwards. Shh, it's bedtime. And UD for as directed, yeah, ut dictum, literally again, as directed. Well, what's in a controlled substance? A lot of people want to know that. I know you have a handout, my friends, and I know I uploaded it, and I know you probably have it. So on your handout, and I'm going to try to find the exact slide here to help you out. Let me see if I can do that for you. It's going to be on, I think page 3. Yep, at the bottom. You're going to see where it says prescription writing and the schedules of controlled substances. Schedule 1, no accepted medical use, like heroin. wait a minute, what the heck is a schedule? And haven't I heard enough about heroin yet? Well, let's answer both of those questions. This is a schedule of controlled substances promulgated by the DEA, the Drug Enforcement Administration. And they're saying that they're going to put drugs that are addictive in schedules and give it a number. The lower the number, the more addictive the substance. And therefore, if it's a really low number, like it's a drug that, wow, I'm going to get addicted almost immediately, we're going to say it doesn't have an accepted medical use. So Schedule 1, a drug like heroin. Many people believe it has a medical use, but officially, no, not so much. Schedule 2, high abuse potential like Percocet. Schedule 3, moderate abuse potential like Vicodin. But here's where I'm going to ask you to take your pen and cross out Vicodin. I do this on purpose. I include this error, number one, to make sure you're still listening, but number two, to show you how sometimes schedules can change. So until relatively recently, Vicodin was Schedule 3, meaning it was less addictive than Percocet at Schedule 2. But the DEA rescheduled Vicodin into Schedule 2 now. So scratch out Vicodin into Schedule 3 and write it in right next to Percocet in Schedule 2. That's a good example of how things change in this profession. Well, you might say, well, wait a minute, Viola, you cheated me out of a Schedule 3 substance then. Great, you can write this one in instead. Tylenol with codeine is a Schedule 3 substance. Schedule 4 substance like Valium or Xanax. Wait a minute, I've heard Xanax is pretty addictive. Yeah, so have I, but it remains in DEA Schedule 4 as a low abuse potential. And Schedule 5, Robitussin with codeine. That's the least abuse potential, so much so that in some states it's available without a prescription, like Robitussin with codeine. Well, then that begs the question, what's the difference between the FDA and the DEA? Well, the easiest way to remember this is the FDA determines whether or not a drug can be sold in the United States based on two things, really. Is it safe and is it effective? Nothing mentioned here about whether it's addictive, right? The DEA, the Drug Enforcement Administration, well, they're not so much concerned whether the drug is safe or effective. That's the FDA's job. They're concerned with, is this thing abusable? Is it addictive? If so, we're going to put it in a schedule and we're going to control it, hence controlled substance. Finally, we have the FDA pregnancy categories. Now, I will give you a disclaimer right up front, my friends. The FDA no longer does this. They do not list drugs in categories for pregnancy safety. Up until 2015, they did no more. But we still use them in dentistry for local anesthetics. And the reason is because we very rarely get a new local anesthetic in dentistry. And just because the FDA has not done this anymore for new drugs doesn't mean that older drugs that were put in categories, that information is still valid. So what does that mean to me, Viola? Well, you can take this. Category A drugs, pretty rare. It's hard to find a drug that's been proven to be safe in pregnancy. They're out there, but they're not easy to find. I think it's because, as a side note, it's probably hard to find people who are willing to take the studies and actually, be volunteers. So what about local anesthesia again? Well, we have two local anesthetics that are category B drugs, lidocaine and prilocaine. We have three anesthetic agents that are category C, articaine, bupivacaine, and mepivacaine. So that's a good example of drugs we use in dentistry that have different pregnancy categories. Well, what are you saying? Does that mean that lidocaine and prilocaine are safer than the other three? Well, at least according to the FDA, they are. Although you'll find in practice, most dentists and hygienists use them interchangeably. Let's put it this way. We should probably avoid drugs in category D or self-explanatory category X in pregnancy. And lucky for us, we don't really have many drugs in dentistry that fall into those categories. So that's an example of how the FDA has established things like safety and efficacy, not only for the general population, but also women who are pregnant, or as I like to say, women infected with the alien. But we say that with love, my friends. You'll see why when we get together in our live session. Why call them aliens? Because we love them. And we want them to be safe, and we want to make sure that we use TLC when dosing them and giving them medications that might be harmful to them. Well, I think that's it, my friends, for our first lecture. Hopefully that wasn't too painful, in a little bit about 20 minutes or so. You'll get to see me live soon enough. And until then, I wish you all well and look forward to seeing you soon.